The question is in regards to what the next 5 years will bring in terms of the treatment of transplant TMA. I think we're in an exciting time right now. For the last 2 decades, and nobody's paid attention to TMA because there was really no effective therapy. With the advent of the complement blockers and with a better understanding of the pathophysiology of this disease, there's now renewed interest in this realm. There's still a lot of work that needs to be done in terms of tying down a good diagnostic criteria, as well as finding good biomarkers to help us diagnose the disease. We now know there are certain risk factors for this disease. If, for example, genetic testing of patients to look for predisposing genes might help us target certain populations to screen and to use prophylaxis in. And then once we are more cognizant of looking for this condition during transplant, we're more likely to diagnose it earlier in the course by implementing more stringent screening, for example, screening for hypertension, screening for proteinuria, and then being vigilant to the diagnosis will allow us to diagnose this condition earlier, and having tests to look for complements will help us decide who might be the best candidates for intervention with complement blockers or with a drug like defibrotide. So I think now there's a lot of interest in this disease because there's now potential effective treatments, and this would be a major step forward because I think it will help improve our transplant-related mortality, because much of the mortality after transplant from graft versus host disease are probably intertwined with morbidity from thrombotic microangiopathy, which, in my experience, tends to go hand in hand with graft versus host disease. And graft versus host disease is one of the most common complications of transplantation.